Hello, welcome to your lecture on Alzheimer's disease. We're also going to talk about reversible forms of dementia. Alzheimer's is the most common cause of dementia, and your patients are going to present with memory and cognitive function that starts to interfere with their ability to perform their usual daily activities. AD is a degenerative disease and it's non-reversible. It's characterized by multiple cognitive deficits and deterioration of global intellectual ability. The dysfunction involves memory, which is usually a very early symptom, behavior, personality, judgment, attention. Language tends to be pretty early as well, abstract thought, and then other executive functions. So remember that memory impairment is probably going to be your most prominent early symptoms. Unlike reversible dementia, the neural exam in AD is probably going to be pretty normal. The only thing that it's going to show is cognitive deficits, especially if the patient comes in with mild to moderate disease. But you have to always think about the other conditions that could account for the progressive deficit, and you need to be very vigorous in your diagnostic investigation because we need to diagnose this or whatever's going on as early as possible so that we can intervene. Alzheimer's disease is actually diagnosed post-mortem, and that's the only way that we know for sure that they have had Alzheimer's disease. But we are very good at recognizing the disease now and diagnosing it at least enough to help us with treatment. When the patient comes in, the first thing that we really have to make a decision about is what kind of dementia this is. I mean, is it confusion, is it delirium, or is it truly dementia? Confusion is just a disturbed orientation of person, time, or place, and you guys have seen this a lot in the hospital. And it can be caused by metabolic problems, infection, medications, alcohol, lots of different things. Delirium also is a very sudden occurrence. It usually has a short duration. There is cognitive impairment, but usually it can be traced to disease process, and that also needs immediate treatment. And then we have dementia, which is a syndrome characterized by impaired short-term memory and long-term memory, plus impairment in one of the following: abstract thinking, judgment, speech, or personality. So loss of cognitive and social ability severe enough to interfere with daily function. Remember that Alzheimer's is non-reversible, but we can sometimes treat the symptoms. So what we're going to kind of go through now is how to figure out if this is something that you can treat immediately in primary care, or is this something that needs to be referred on immediately. So we're just going to kind of talk about that. I really like this. It has helped me kind of remember the things that I need to be thinking about when someone comes in with confusion, delirium, or dementia, and we're kind of not sure what's what. So the first thing you need to think about is D, drug intoxication, anticholinergics. Think about your polypharmacy, but also think about alcohol abuse at this point, which we don't really want to think about it that much with elderly, but it is pretty prominent. We tend to be okay if it's an older man, but for some reason if it's an older woman we usually don't address it, so always think about that. Think about sensory loss that they could have, eyes and ears, cataracts. Also, if they're in a brand new environment, sometimes that can trigger a very acute confusional state. So there are lots of reasons for dementia, and we have to figure out exactly what it is. So we're going to talk about the different imaging and diagnostics that we need to do. You want to make sure that you rule out treatable causes of dementia. I mean, it would be a little bit embarrassing to send a patient to a neurologist and find out that you had missed hypothyroidism. So that's why we need to do a really good workup. That, in addition to the fact that we need to be able to immediately treat whatever's causing this. M is metabolic. Especially with polypharmacy, you can get into a lot of issues, but you want to think about hyponatremia, hyperkalemia, hypercalcemia. All of those kinds of things can make a difference. With elderly, we've always talked about with medication, start low and go slow. But by the time that you add on lots of different medications, I mean, I've seen patients who are on 23 different medications, so how could you ever figure out what's interacting with what? The E stands for emotional and endocrine, and that also includes major depressive disorder, schizoaffective disorder, bipolar, chronic schizophrenia, and then pseudodementia, which is depression masking as dementia. Also, you got to think about hypothyroidism, hyperthyroidism, hyperglycemia, hypoglycemia. One of the big questions is trying to figure out, how do you distinguish cognitive impairment from depression? And one of the ways that you can do that is the amount of effort that a patient is willing to expend on the cognitive task. So if you ask them to do a mini mental exam, the effort and attention are generally poor in a depressed patient. They don't want to mess with it at all. But if you have a patient with Alzheimer's, I mean, they're going to really put forth a lot of effort and try to do a really good job. And then when they can't remember something, they're going to get really frustrated by that, especially if you see them early on. Because when you see them early on, they are aware of the deficits that they have. And so this is a source of great distress to them and great frustration. So when you do the test with them, they really do everything they can. Now, if you have somebody that's really depressed, you can't hardly even get them to engage in something like your MMSE, and that may be some of the true difference. It's really hard to differentiate between pseudodementia and dementia, and hopefully we can pick it up, but if we can't, that's okay. Maybe the neurologist can. Most likely this is an older person, so you always have to think about neoplasms and any other kinds of neurologic kinds of things, malignancies that started other places that maybe have progressed to the brain, and that can happen quite a bit. They also may have a new onset of seizure, and that's a new thing. So if you had somebody, a heavy smoker, and maybe lung cancer was missed, and that's one that's very common to send mets to the brain, then they may start with a seizure disorder instead of this kind of confusion. So you see lots of different things, but the big thing about Alzheimer's is that when you do your neuro exam, it's going to be pretty normal. Okay? Now, if you have somebody who has a neoplasm, Parkinson's, those sorts of things, they're probably going to have some changes in their gait, or other parts of their neuro exam is going to be abnormal. You always have to think about trauma. Chronic subdural hematoma is probably the most common, and you got to think of this is somebody who maybe has some gait disturbances, and maybe they've had some falls at home that they haven't talked to anybody about. So it's always got to be kind of in the back of your mind. The I is for infections and inflammatory, and you've seen this a lot in your hospitalized patients. They get a wound infection, and of course they start going with a lot of confusion. Infections in nursing home patients, and then your primary care. Lots of times I have seen older women come in with confusion, no other symptom at all. You get a urine on them, and they have a raging urinary tract infection. You clean that up, and everything goes back to normal. So it's always something that you have to think about. And as weird as it is, I've had that happen several different times. So with the older women, they tend to not have the symptoms of burning, frequency, and all those kinds of things. Or, they may have had incontinence for a long time, and they really don't notice any difference between what's been going on for the last 5 years or 10 years with what's going on now. So it's something that they really don't pick up on a lot, and it causes this acute confusion that is very easily resolvable. So if you see that, always get a urine. Inflammatory, a new onset um, of any type of inflammatory, especially if they've recently been started on prednisone. That can rev some people up and cause them to have lots of problems. You got to think about anemia. That's your Alzheimer's, other dementias. Okay, so the main things that we've kind of talked about with dementia is you got to look for other neurologic deficits and things that could be causing this. And remember that with Alzheimer's, that they tend to not have any other neurologic deficit other than their cognitive function. Alzheimer's is the most common cause of dementia. Vascular dementia is second. Depression and dementia often coexist. They have to be evaluated and they have to be addressed individually. Now, sometimes the patient will even start to recognize that they are losing their memory, misplacing things, getting lost. Their sense of control is going away. That induces the depression. So they very often coexist, especially in the early stages when the patient is still able to figure out that something's off. Now, later on, they're not even able to figure out something's off. So actually, the disease gets a little bit better for them, but worse for other people. If they have gait difficulty, then think about Parkinson's or other kinds of related syndromes. All right, if somebody comes in with new onset of dementia, it takes quite a big workup to do a good job with this. You want to get a CMP, look at your electrolytes, your BUN, your creatinine, renal function in particular, and then also your calcium. You want to look for anemias, you want to look for B12 deficiencies, you want to look for infections. You want to check the thyroid, look for any abnormalities. You also have to look at your liver function test to make sure that they're okay. You're trying to make sure that hepatic encephalopathy is not present, and also that you're not overlooking alcohol abuse. In some patients, you may want to think about ruling out syphilis, and you may want to think about ruling out HIV. Most of the time, unless there's a contraindication, you want to get an MRI. You're looking for infarctions, hemorrhage, mass lesions, hydrocephalus, any of those kinds of things, or other structural abnormality. The MRI can also help differentiate between some types of dementia. Now, your other option is to do a CT scan, and you may have to do that if there's a contraindication for the MRI. If they're combative in any way, you're not going to be able to get an MRI. If they have a movement disorder, that's going to be a big difference as well. But before you get either one of those, you may want to send to a neurologist and see what kind of tests that they would get. That's probably what I would do. I would probably do my initial lab work, try to get all of that, and then I may go ahead and refer if all of that comes back okay. If you're thinking about vascular dementia, you have someone with uncontrolled hypertension, cardiovascular disease, dyslipidemia, all of those kinds of things, you may be thinking more about vascular, and so you may want to look at your carotids, or you may want to do an echo to see if they're throwing some type of emboli, those sorts of things. So it can be pretty complex. So you can get help with a specialist. You don't have to do this by yourself. So what are your responsibilities when it comes to treatment? Well, you need to take immediate action, and you need to exclude your other possible diagnosis. You need to assess safety. Are they driving? Are they wandering off? Are they cooking? All of those kinds of things. Have they been violent at all? All of those things. So think safety. And that's a big thing that you need to talk about. You need to go ahead and refer as soon as you can, especially if the patient's younger, or if you think for any reason at all that there is a psychiatric comorbidity or there's a behavioral disturbance. You may want to send to a neurologist or a psychiatrist, but I would probably myself choose to send to a neurologist. And you need to do that for any patient with new onset dementia or any patient who has any type of cognitive decline. Now, if this is a family history of Alzheimer's, then especially in a younger patient, that's when you may start thinking about consultation with genetic counselor, those kinds of things. Once AD is diagnosed, that is an ongoing education for the family and the patient on the prognosis treatment options. It can be very detailed and very complicated. You can refer them to books. There's lots of information. This is going to be most likely a very long process. Patients need to have a nutritional consult, social worker. They need ongoing support services, and you need to evaluate who's going to be there with them, who's going to take care of them. Um, you need to take into consideration the patient and family values, and you need to always be thinking about the highest quality of life possible for the patient.